Great, no, thank you so much. I feel quite privileged to be here today, and it was also really nice walking the room and seeing a lot of people's faces who I haven't seen in quite a long time. I've since moved on from my role in NHS Lothian working in sexual health and HIV, but then coming in today, I was like, oh, actually, it's really nice to be re-engaged with this group about a year on. So thank you again. I'm hoping today to set the scene a bit around the conversations that will come, because back in 2018, I completed what we called a health needs assessment. I'll describe what that means, but this was looking at aging with HIV. And to Nathan's point around us needing to start running rather than walking, I very much feel that this was the training phase, if you will, as far as what do we actually need to kind of start setting pace so that we're ready to start running. And in some cases, we already are in certain sectors. And hopefully that will be illustrated today. But I should say I am representing lots of different voices. So we had over 34 people contribute to this needs assessment, as far as 34 people with lived experience with HIV. And we'll go into their stories, but I hope that I represent that accurately. And if I haven't done so, I do welcome that feedback, because I think it's really important that we get this right. So if there are comments at the end, I'll be happy to take those and happy to have that conversation with you. So, moving on. The purpose of the assessment, which started in 2017, and this was directed by HIV Care and Treatment Group, run by the NHS Lothian, but has various stakeholders from both the public sector, being NHS, social care in some instances, HIV care services, and third sector as well, as far as Waverley Care representation. So the group agreed that we need to do a bit of a deep dive into aging with HIV and really figuring out what we need to be prioritizing. So the purpose of the assessment was to assess the health and social care needs of people living with HIV in Lothian who are age 50 plus. And the reason we chose that number is not because people are old at that age, which we had to certainly reiterate in a few of the interviews. It was just to say that if we're putting planning in place, that sometimes it takes 10 to 15 years lag time, that we are ready when this cohort might be ending towards the end of their careers, 65 plus, and we have those systems in place. So we're looking at to assess the extent to which these current services are meeting our existing needs, but also the anticipated demand in the future, making the recommendations of planning the delivery of HIV services, and maybe considering how do we deliver them differently with new technologies emerging, et cetera, and new models of care in the community. And then also highlighting training needs from within the NHS, social care, and care home sectors, and beyond that as well. And then also ultimately, and to the importance of today, identifying opportunities to address HIV stigma. So the health needs assessment approach that I explained, it really has three components to it, and each study can be slightly different, but essentially what it does is it combines three kind of different data sets together to kind of round out and provide a whole picture perspective to it. So the top one is epidemiology or epidemiological data. So this is population data. So looking at demographics, different characteristics of the population, how do we describe them? What are their health status points like? So we're looking at demographic data, specifically in this clinical data to highlight multi-morbidities, access to health services. Unfortunately, we didn't capture, and there's not a lot of data sets around social care access that we were able to tap into for this. So that was a gap, but we felt that we were addressing those kind of social care components in the next section, which was the experiential. So this was talking to service users and those with lived experience with HIV through focus groups and in-depth interviews, along with service providers themselves from a range of sectors. And that's really what I'm going to focus on today are those 2 points. The last one was something that we call a comparative. So this was looking at what's actually happening in practice and how does this measure against various guidelines? So the guidelines, and quite timely was in 2018, there was a National British HIV Association clinical audit that was looking at the care provided to those 50 plus across clinics in the UK. So it was quite timely, and the recommendation from the report that I was able to produce said that these recommendations need to be viewed alongside this audit to make sure we're really tying everything together. So quickly, the demographic data, and I'm not going to go into too much detail here, but I think it's important just to kind of describe who we're talking about and who was I really trying to engage and represent in this report. So from the data in 2018, we could find that there's 695 people living with HIV in Lothian who are engaged with health services, and that this cohort makes up approximately 50% of all those living with HIV in Lothian at present. Now those figures have changed slightly, but that's really what was used in this time. About 80% are male, 20% are female, and as far as ethnicity, about 86% white, 94% black and minority ethnic, and 5% other. Part of our view was also looking at kind of clinical indicators, so we thought it was important to look into the point of the first HIV test. So the majority of the cohort had their first positive HIV test prior to 2005, But interesting, a third of the cohort, so about 30%, were diagnosed prior to the introduction of effective treatment, so triple therapy in 1996. So we tried to use that when analyzing the data and access to health services just to see if there was kind of correlations or relationships there. And the reported exposure categories across those groups, about 43% MSM, so men of sex with men, 34% heterosexual, 14% injecting drug use, and about 8% other unknown. And that was at the point of what was reported when people's tests were reported as positive. And just briefly, just to show you the distribution, this is really why it's quite timely as far as this kind of walk-run analogy, is that we have quite a large cohort in that kind of 44 to like 54 time block, or 45 to 54 time block, that we're going to see that kind of shifting forward in the future. So it's no longer going to be 50%. We're going to be looking at probably 60 to 70% of the cohort in the coming years shifting into that region. So enough of that data. So here's the kind of the more meat of it. So the service providers that we engaged, we had 6 different HIV services across health, social care, community, and third sector who we engaged through various networks. And here are just a few of their themes. And I've really drawn out the themes regarding social care and stigma, specifically for this presentation, but there's a whole report that talks about the health indicators as well. So community resources. Lothian is fortunate enough to have a large number of dedicated, well-resourced community-based organizations. And that's actually was seen as a huge asset in comparison to some maybe other regions. However, there was concerns about the number of people who might not be accessing these supports. And a quote from a service provider was, even though they may be infected or affected by HIV, they don't necessarily want to use an organization specifically designed to support people living with HIV. So I think that's quite important for us to recognize. And that also goes back to challenging stigma as well, as how do we maybe look at across services, are we providing support no matter where people want to engage? Another theme was patient consent for HIV disclosure. So we felt it was a good time to revisit this as far as if we're going to have multiple stakeholders managing people's care, then we need to be looking at who's aware of their status, if that's important to the care that they're receiving. So this is something that has to be worked out further, and I'll go through the recommendations at the very end. But a recommendation that seemed to be coming up from service providers is that if we're going to be engaging specialties and services beyond the health sector, how do we communicate that status? Because a lot of participants then would share of this kind of standoff that they would have with a new professional or a new person of, oh, do they know my status? Do I have to say it first? Who's going to say the H word? And it was like this seemed to be a common theme in at least a few interviews. So that's also about addressing stigma, but just something for us to consider as maybe a point moving forward. A learned dependency. So this was represented by a few service users, and I have a quote on the next slide which maybe expands that a bit further. But the need for us to kind of consider how are we managing realistic or unrealistic expectations around HIV care and support. And the example they gave was that the care that was provided back during the height of the epidemic and then into the early 2000s was more about how do we provide better end-of-life care or palliative care. That's changed, and that's quite a success, and we need to be celebrating that. But at that time, because of that being the focus, there was more resource, there was more finances available and teams available to support it. So that's illustrated by this quote. As far as 30 years ago, we set up supported accommodation specifically for people with HIV. We had a model where we supported people with everything, so this whole holistic approach to their care. But in that case, the model used to be supporting people to die well, whereas now it's more about supporting people to live as well as they can. A lot have come to us expecting this package would still be there waiting for them, but it isn't anymore. With effective treatment and better support from social care, people lived longer, so we have now had to rethink our model. So just kind of think about that as we go through some of the other themes. Care home suitability and availability. We touched on this briefly with a few of the stakeholders, and this was from the social care team. They said it's less about HIV being the issue with care homes at the moment, it's more about their drug use. So some clients will be continuing to inject drugs or use drugs, recreational drugs. So we have people in their 60s and 70s who still want to inject and who will need a care home placement in the future. So this was recognized as a significant gap in our knowledge. So we've asked for that to be a recommendation as far as assessing the readiness for care homes for this cohort at the present. So moving on to service users, so this is their experience. So I interviewed, along with a colleague, we did focus groups with as well. We had 34 people living with HIV participate, and that represented collectively 700 years of experience. And I think that's quite important when you put all that together. It's not just about 34 people, it's about that many years of experience that has contributed to this. It's important to recognize there were some limitations of it, and this was well noted throughout. So not everyone who probably should be participating in that were able to, and that was likely due to travel or health conditions or health needs. So there could be a gap in, but maybe we're not having the whole holistic or whole understanding of the situation. Only those involved were currently engaged with support services. So we used handily, we recruited people who were already engaged in services. So maybe we're missing a cohort, as I mentioned before, who haven't engaged in that. We missed some in-depth detail around BME populations experience, so sorry, Black and minority ethnic. And then we also didn't have people who had direct care home experience participating in the interviews either. So just be mindful of that as I go through some of the further themes. So communication of status. So linked to above as far as disclosure of HIV status, people felt that there's poor communication of this across the health and social care system, and that should really be linked up, especially if we're looking at a whole support to people. It's just easier to go to the HIV clinic as they know my status. And lots of examples were given to this around, they'll go to their GP, they have a question, and then either they can't get a GP appointment, which is a different issue, or they would go to the GP and say, you know what, I'm not too familiar, you should just go to the clinic. Or I can get an appointment at the clinic quite readily. So maybe there's a need for us to kind of look at how we're providing that care across the pathway to the patient. Stigma, and this slide could be a whole presentation. I've had to condense it down. But individual stigma, interpersonal, so family, friends, societal, or an organizational. The organizational bit I'll pick up on as far as access to services. Specifically for social care, there was no negative comments that were shared back at the time specific to the care provided there, or any stigma existed in the care that was provided. But access to that care, whether in a rural setting or an urban setting, was different. However, and unfortunately, there were so there was several instances where people were sharing stigma that they experienced from health professionals within the NHS and interactions they had there, which was quite concerning to hear about. But again, we picked up it as a recommendation and have processes in place now to address that. So just around stigma, the disclosure of one's status never stops. So it's this continual process, it's that continual standoff that we keep hearing about. And people comparing it to other conditions. If I had diabetes, I wouldn't feel that same stigma as I do as having HIV. And then people also reporting having discrimination based on their HIV status and in some cases their sexuality. Social connections. By far, this came through whether people talked about it direct or not, or just themed out of the different data that I analyzed. So importance of support groups and networks to combat isolation was by far one of the most important things that a person could have in their life. And that support group could also be their family and friends, but as long as they have that. So HIV organizations are a catalyst for meeting people and making connections so you feel like you're not alone. Another theme was the need for additional mental health support. So there's a fatigue about living for so many years with a condition that is now non-life threatening, but used to be. There's a sense that we should just get on with it because now it's all okay. But that legacy and that memory still remains. So how do we make sure and we dedicate time and effort to ensuring that we don't forget that? Financial support, this is the big one. So the system is very difficult to navigate, which is compounded further when evidence is needed to confirm entitlement to benefits, in particular to a personal independence payment. So this is one person's experience. I recently had to go for an assessment for PIP, which was the most embarrassing and patronizing experience that I've had in my entire life. I had to get letters from everyone involved in my care, describing my health conditions, and in so many ways the assessment was scrutinizing. And this was a theme over and over and over again, just the sheer amount of work that was involved in collating all that. And you don't think about the expense that takes as far as even just going to these different clinics to collect that evidence, to get that data, or to get those letters and pull it together. So a few other things around financial support. There's significant concerns raised around finances and sustained access to benefits that many are currently receiving. So one person said a sense of feeling trapped at the moment. That's how it felt when I was first diagnosed, trapped and overwhelmed. And that's how people are feeling now in their financial situations. And that support, however, there was some silver linings that were highlighted. So support provided by Waverley Care staff and the Edinburgh Alcohol, Drug and BBV social work team was invaluable. So these are people who are working with the clients to actually sit down and say, what can we do to support you? And that really shone through throughout the assessment. And this sense of caught in the limbo, and I think it's actually quite central to a lot of the work that I've highlighted so far. So we were told to prepare ourselves to die, and then we did not die. We are still living, but haven't made plans like a pension, etc., other plans in life as well. This leaves you in a strange limbo. It is quite difficult for people to find employment, to go on to other careers, but many are struggling to find jobs because they do not have qualifications due to not being able to go to university or whatever. or they haven't made plans for their pension or retirement. So just understanding, like, it's not like in some cases life almost stopped in the 90s, and then it's like, well, it's continued, but sometimes people are left behind, or we don't recognize the supports that should have been there and could have been there to bridge that. And now we have to provide those supports and or find ways to do that. And finally, just one specifically around social care provision. Individuals who were engaged with social work teams receive support with housing, adaptive aids, and household chores, example, weekly food shops. And that they're very largely positive about the experience and the service that they received. However, like I said before about the institutional stigma, whether this is intentional or not, around inequalities of access, so the rural experience. So one individual shared, basically social work support for HIV is non-existent in my community. The services in Edinburgh are better, which is why I likely have to move. They just don't have the manpower, so it's more Edinburgh focused. It can be a bit of a postcode lottery, which is why I likely will have to move into the city. And just think of all the resources that would take, and Edinburgh is not a cheap city to live in either. So just that compounds the things further. And we talk about equality of access and care, and sometimes we can be quite centric in our thinking. And that's why it's important to be engaging with our health and social care partnerships and public health, who are looking at making sure we have that equitability of access across the system. So loads of recommendations. I think it was 18 or 20 recommendations in total came out of the report. I won't go through all the detail of them, but the four kind of main headings or themes for them were service reconfiguration, training, and this is where we're going to be picking up a lot of the institutional stigma that might exist, and making these things mandatory for at least NHS staff and also health and social care staff. Clinical assessment and provision, supporting patients in care homes, with that one actually leading on to kind of a further review or deep dive into what care is being provided at present and what do we need to do to shift that to meet the upcoming demand and needs. And underpinning that, and I think this shone through at the very end, and certainly had the buy-in from the HIV care and treatment group, was that underpinning it and foundational is the involvement of people living with HIV as partners in this process, so that they are helping shape and co-design these new systems that will suit them and not be something that they're just given, but something that they actually feel that they've contributed to and had value in. So thank you very much.